here today with Dr. Gordon Slater for part 2 of our series on ankle reconstruction, and we're just going to have a brief discussion on what's called a Jones fracture, specifically about Kevin Durant. So can you tell us about Kevin Durant's initial surgeries and why they were unsuccessful?
Well, you know, the question of the Jones fracture, and luckily I've got my model once again here, but Robert Jones, you would probably remember from your physio lecturing days, Chrissy, is a fracture of the fifth metatarsal, and it's in what's called the diaphyseal section. So it's an area with the metatarsal. It's got a notorious for having a poor blood supply. Fractures in this area, and about 60% of people have some sort of problem. The problems are things like delayed union, or even non-union, which are big problems for a fracture. With Kevin Durant, he had an NBA basketballers, for some reason, have quite a high incidence of this as a problem. And for them, when they're on enormous salaries, getting them right is, you know, of paramount importance to them. So Kevin Durant's fracture, from my understanding, he had the fracture and he had screw fixation of it, which failed on 2 separate occasions. He ended up with a good mate of mine who I trained with, Marnie O'Malley, and so the third surgery was a combination of a bone grafting technique and also a screw fixation, but a large screw in his instance, because, you know, these guys got enormous feet, they're crazy. So I would generally use a 4mm screw, and in Australia that's all I've had to use. And in our series we had 67 cases, all with a 4mm screw, all united up except for someone that had one for 10 years. So they've been there for a while, which Kevin Durant's have been there for quite a while by this stage, and failed attempts to fix. So he had that, he had bone graft, and he had an external bone graft stimulator in order to get it right.
Gordon, how would we then rehab a Jones fracture? How would that be different to a normal ankle reconstruction surgery?
So it's different because you've got to protect it. So when you've got something that we're waiting to unite up, in the early phases it's more about what you don't do rather than you do, right? But I think as a physio, you can see a lot of these come in, and it's early recognition of someone. They can present like they've got a sprain, but in actual fact they've got a Jones fracture or a styloid fracture. And the rehab is very different. Like in an ankle sprain, you're trying to go for that early mobilization, and you're of course icing and doing all those great things with it. But the Jones fracture or a styloid fracture, early recognition is important. And that comes down to a good clinical exam. Palpate around. If you get pressure points around the fifth metatarsal, you need to get an X-ray done. And in fact, early X-ray, with people that have a lot of trouble weight bearing or failure to progress in your physio, you need to start to think what else could it be. In terms of the actual fracture, then once it's united up, and that can take a bit of time. With my Jones fractures, I put the screw in. I generally, depending whether they need bone graft, whether it's early, whether it's a revision, but if it's an acute fracture, we put a screw in. We can do it minimally invasively. It's generally 1 stitch. A wire goes down the fifth metatarsal, so we can place the wire, and luckily the fifth's, it's got a nice entry point. You can put a wire down, it sort of travels down the bone, and then the screw goes over the top of it, and the internal compression then fights against the forces that are trying to pull it apart, the perineal tendons, and which causes you delayed union. The delayed union also occurs because joint fluid can get into the fracture, particularly with some of those styloid fractures that do have a diaphyseal extension. And so early recognition, and then once we've done it, then you want to wait until the fracture's united up before we start aggressive rehab. But they'll generally start at about 3 or 4 weeks with just some linear, movements once again, a bit like an ankle reconstruction, and then you watch for that eversion and the firing of the perineal tendons. You don't want to work against the fracture and delay the union.
Yeah. So this one has a period of non-weight bearing.
Depends. So if it's grafted, if it's separated, yeah, I do non-weight bear them for a period of time, and I make that call in surgery depending on how much compression I get. If it's an acute fracture in a well person, I generally get them touch weight bearing in a bit, generally about 24, 48 hours post-op. Yeah. Yeah. So not that long, but still, we're watching it. And this is a little bit different. This screw, it can stay in or it can come out. It can cause problems, with the tendons and a bit of irritation. To probably taking out about 10% of the screws in this situation.
Yeah. And is there room to trial conservative management if it's a smaller fracture?
Yes, so you can, and they always get that option.
Yeah.
So it's it's a balance of statistics. So you say, look, you have this fracture. If we put a screw in it, I believe that it's going to heal up a lot quicker than if we don't.
Yeah.
But we can still go down a conservative path. You can
Yeah.
put your hand up for surgery. You know, if you're getting frustrated,
Yeah.
we're like 2-3 months. You know, I'm sick of it. Well, then you put your hand up and we can get you out of trouble. And it comes down to, you know, you I suppose conservatively got about a 50% chance you're going to get some problem,
Yeah.
non-union or delayed union.
Yeah.
And so screw fixation, it's that risk-reward equation. Some people are very surgical adverse, and they're good ones to, of course, trial. And you might be a diabetic or something like that, and you're thinking, well, you might be worried about it, or you know, some other health risk. But if you're young and fit and you want to get back to sport, and you want a consistency in your result, then screw fixation, I believe, will give you, you know, a greater balance in that. And the downside of, you know, low rate of infection or injury to nerves, that comes down to the patient's willingness to, you know, to take the risk on that versus the risk of some problem that it doesn't unite up and you need surgery anyway.
Yeah. And in terms of return to sport following a reconstruction of a Jones fracture, what are we looking at for that?
That's a little bit longer than an ankle reconstruction because we've got to wait for the bone to unite up. So depending on what sort of sport, again, I like to see the fracture pretty well united up. We generally got radiological confirmation of that at about 8 to 10 weeks.
Yeah.
So it's a bit longer. If you go back earlier and this re-fractures or the screw fractures, that's a big problem. You want to avoid that.
Yeah, absolutely. Thank you very much for your time today, Gordon.
That's my pleasure, Chrissy.
And if you've got any other questions about your ankle rehabilitation, just come and see us at Enhanced Physiotherapy.
Thanks, Chrissy. Well done.